Today is February 15th of the year 2024. It's the day that we are celebrating the International Childhood Cancer Day in Kenya and also the whole world. Basically, the main essence of us celebrating or actually doing this is to actually collaborate within ourselves, that is the various facilities, the counties, the national government, together with the global village, to raise awareness about childhood cancers and the unique challenges that we have in regards to the same. We also probably express support for children and adolescents who are battling cancers. We have various children out there who have cancers, the cancer survivors that are out there and their families who also form a core support group for these children. And then also to highlight the importance of community participation and support in addressing the challenges which we might have in one way or another related to childhood cancers. So on the call today, I am highly honored to, first of all, introduce Dr. Alice Gishemi, who is a pediatric hematology and oncology fellow at Moi Teaching and Referral Hospital, to take us through this session. Dr. Welcome.
Thank you very much. Just a minute as I share my screen. If you could stop sharing yours. Okay. Welcome to today's session, and we're going to be talking about early detection of childhood cancer. As we are aware, today is the International Childhood Cancer Day, and it is dedicated to children with cancer, especially to those children who have cancer and are not being treated for cancer. People do not know they have cancer, and they go through their illness without anyone ever having given them that diagnosis or offered them treatment. So I'll go through the introduction, the epidemiology, some common presentation, early warning signs, survival, and also the available Ministry of Health learning resources that we can all use to know a little bit more about childhood cancer. So cancer, as per the WHO definition, is a large group of diseases that can start in almost any organ or tissue of the body when abnormal cells grow uncontrollably and go beyond their usual boundaries. When they do go beyond their usual boundaries, that's when they are termed as metastases. So when you look at the various categories, there's quite a wide range of pediatric cancers, but we mainly give them two broad categories, that is the hematological or hematolymphoid and the solid tumors. The hematological cancers, these are leukemias. It can be acute lymphoblastic leukemia, which is the most common leukemia in children, acute myeloid leukemia, and chronic myeloid leukemia. In children, we usually do not get the chronic lymphoid leukemias. And then we have the lymphomas that are broadly categorized into two, that is non-Hodgkin's lymphomas and Hodgkin's lymphomas. For solid tumors, usually we name them according to the kind of tissue from which they grow. So for adult cancers, you'll find somebody, or rather they are named after where they are. So you have breast cancer, you have uterine cancer. For pediatric cancers, it's according to the tissue from there they come from. So Wilms tumor is a kidney tumor, is the most common kidney tumor in children. Among the sarcomas, you have those sarcomas that grow from muscles, that's rhabdomyosarcoma. There are germ cell tumors from germ cells of the testicular and gonadal tissues. You have neuroblastoma from the sympathetic nervous system. You have retinoblastoma, as the name suggests, from the retina, and a wide variety of brain tumors. So when you look at the epidemiology, childhood cancer is not as much as adult cancer, but it's when you have children who have cancers, they actually do get to have their cancer cured better than in adults. And in children, these are people who are very young, they have their entire life ahead of them. So they have a better chance of cure. We need to give them that. So you have 160 to 180 cases per million children per year. So annually, we have 400,000 cases annually globally. So the commonest childhood cancer of them is acute lymphoblastic leukemia. The second most common childhood cancer would be the brain tumors. And we're going to look at the epidemiology in Kenya and see where we are failing when it comes to brain tumors. The third most common is the lymphomas, both the non-Hodgkin's lymphoma and Hodgkin's lymphoma. So looking at the landscape in Kenya, when you look at that global data, where you have a rate of between 70 and 160 per 1 million children per year, aged between 0 to 14. The other one was both children and adolescents. But when you look at 0 to 14, which is the age groups that we meet in our pediatric cases, it's about 70 to 160. So on average, you can say that in Kenya, we expect to have about 100 cases per million children between 0 to 14 years. And our Kenyan population stands as per the 2021 census at 53 million. 40% of this population is aged between 0 to 41. We have a total number of children of around 21 million, aged between 0 and 14. So when you look at the expected, extrapolating that data of our own population, we expect to see about 2,200 cases of pediatric cancers per year. Now, if you look at what is actually diagnosed and sent to the treatment centers, Kenyatta National Hospital usually sees around 500 cases annually. MTRH sees around 300 cases annually. Gertrude's around 40 cases. AIC Kijabe 40 cases. KUTRH is a new center, and we are hoping that their numbers are going to pick up. So looking at that number and what we actually have, it means that around 1,300 cases are undiagnosed. And they have not, these are children who present to our facilities, but do not actually get to be diagnosed and sent for treatment. And looking at this, we can actually see that these are half of the cases in Kenya that are not making it to the treatment centers. And these are children that I want us to focus on today. So if you are in a facility and you're seeing pediatric patients, whether it is as an inpatient or outpatient, you're likely to have come across a child with cancer. But are you able to recognize this as cancer? So most times, these children are likely to be diagnosed with malaria or typhoid, or if a child presents with headaches and seizures, they're labeled as having epilepsy or having meningitis. And when they do succumb about a few weeks or a few months later, they are assumed to have been having poorly treated meningitis or poorly treated malaria. And the reason this happens is because pediatric cancer cases do not have very special kind of presentations, other than the ones that do come in with huge masses where you can actually see this is a mass. Most of them do not have any special presentations. They present as somebody who has malaria. They present the same way as somebody who has meningitis. And if I want, what I want you to take home today is that when you see these children, at the back of your mind, have that question: could this be cancer, and what can I do about it? So looking at the data that we have, this is MTRH data, but it is quite similar to what we see in KNH. Between 2006 and 2010, we had non-Hodgkin's lymphoma being the most common childhood cancer that is brought for treatment. And this is because it is something that you cannot easily ignore. It is a big mass. It grows very fast. So it's more likely to be seen. But what that tells us is that our acute lymphoblastic leukemias are not being detected. They are being treated for other things. Same with the whole category of these other lymphomas and sarcomas. Looking at the very last point there, you have brain tumors. At that, during those years, there were only 4 brain tumors that were sent to MTRH. And we've said that brain tumors are the second most common malignancies. They should have been around 100 and something if you look at the statistics, but these are children who are not being diagnosed. So looking at the 2020-2022 data, you can see that improvement in detection of brain tumors, where right now it becomes the 6th most common malignancy being treated in MTRH, but we're still very far from detecting all our brain tumors. We're still very far from detecting, I've said we still have half of those children in the villages that have cancers that are still to be treated or even detected. So when we look at what kind of cancers are we looking for, and in which children, in which age groups do we see these cancers? So the most common leukemias you will find between the ages of 0 and 10, being the most common ages of presentation. You have the lymphomas between the ages of 5 and 9. Once you get to the older age groups after the age of 14, then these are mostly the Hodgkin's lymphomas. Then you have the CNS tumors that occur in all the age groups, but mostly you'll find them between the age of 5 and 9. In red, if you see the red button over there, the red bar over there is the retinoblastomas. Retinoblastomas are cancers of the retina, and usually you'll find these in the early years, between 1 and 2 years. It's quite rare after 5 years of age. You have renal tumors, most common in the age groups between 0 and 4. Let me just get my pointer. Yes. So what are the early signs and symptoms of hematological malignancies? So the signs and symptoms are usually not very specific, but it's something that we can always have at the back of our mind when we are looking at these children. So for the lymphomas, you're likely to get, So for lymphomas, Hodgkin's lymphomas, usually you will find these masses on the neck. It can be anywhere else. You can have them in the abdomen. This is a case of Burkitt's lymphoma, which is an endemic Burkitt lymphoma with that jaw mass. And this one is so rapidly growing that it cannot be ignored. So these ones, you'll find them in the treatment centers. But these cases where you have these small nodes everywhere are less likely to be considered to be malignancy. And that's why we really have to have a high index of suspicion for malignancies. Patients with leukemias, they might present with bruising, they might present with petechia, they might present with bleeding from the gums. Some of them will present with bone pains. These are children that are labeled to have juvenile idiopathic arthritis or even rheumatism. But actually, for those leukemias that, especially if you have a normal WBC count and you have bone pains, that's a patient that you really should suspect to have leukemia. And when we look at our CBCs, this is an actual CBC of a patient that we are currently treating. You can have this WBC with very high WBC count. This is 85 WBC count and 79,000 of which was lymphocytes. Low HB of 52. So pala is one of the presentations for leukemia, and the platelet count was 110, which isn't that low, but is still with below the normal range. Sometimes you will not have this classical picture. You might have a bicytopenia. say you have low HB and low platelet count, but a very normal WBC count, that could still be leukemia. And we really do need to take these patients and refer them early for them to have additional tests done. I'm aware that a lot of facilities, especially in the counties, are currently not doing bone marrow aspirates to diagnose leukemias, but one of the more low-lying fruits would be doing a PBF if you have a pathologist in the county. When it comes to the solid tumors, these are patients that present mainly with masses, because this is a tumor that grows from a certain type of tissue. You'll have them presenting with masses. This is a child with masses on the scalp, that is neuroblastoma. Sometimes they might actually just be, especially for the younger children, they do not have any obvious masses, but they are irritable, and they have this, what we call the raccoon eyes, which is the neuroblastoma tissue in the orbits. Sometimes they present with unexplained weight loss. They present cachexic. Sometimes they are actually have normal weight. If you look at a patient with Wilms tumor, these are normal, happy, playing children with a really huge abdomen, that is abdominal distension. Sometimes they may present with the night sweats and fevers and are treated as having had TB. So the take-home message on this is to have a high index of suspicion for malignancy and take further steps to investigate for malignancies, especially if you've been treating them and they're not doing any better. So when it comes to brain tumors, this is the most missed cancer in children. We are not doing very well as a country when it comes to diagnosing brain tumors. And that is mainly because we do not suspect it. We do not expect our children to be having brain cancers. So at any age group, if you look at the symptoms, they're quite nonspecific. So you can have a patient with recurrent vomiting, persistent headaches, abnormal balance or coordination. They simply not working as well as they used to. You have abnormal eye movements. Rarely you'll find patients with some neurological deficit unless their tumor is quite advanced. And the thing to think about when it comes to brain tumors is this headache new? Is it changing? Is it suddenly worsening? Is it persistent over a period of time? Then let's go ahead and do our MRI scans and check whether this could actually be a tumor, rather than dismissing it as just another headache and a patient who is not taking their medication well. If they're having seizures, sudden seizures in a patient who is not febrile, MRIs have been preached over and over again. If you don't have an MRI, a CT scan is good enough to do, but it's something you really need to think about before you dismiss a patient who keeps complaining of headaches. So if these headaches, so something special about headaches in brain tumors is if you find a patient who's had headaches throughout life and nobody bothers anymore other than giving paracetamol, if they suddenly change in their character, if they're suddenly unilateral, if they are suddenly waking the child up in the morning, if the child is having early morning vomiting, suspect brain tumors, do imaging to rule it in or rule it out. So the other common malignancy is retinoblastomas. As I said, this is usually between children between the ages from birth to around 2 years. This is the only childhood cancer that can be screened. So when we go to the media, when we talk about cancer, we talk about screening a lot. And when we talk about screening, we actually are talking about adults. We are not anywhere near childhood cancer. The only cancer that can be screened in children is retinoblastoma. And the first thing, if you see a child or an infant with a squint, do not reassure at that point. Let them be seen by the ophthalmologist to just check whether this is retinoblastoma. This is one of the highly curable cancers, and there is a chance to save their vision if it is detected early. Sometimes there is a chance to save their the eye even without the vision if detected early. So you'll have this, what we call leukocoria, or the white reflex. And when it worsens or in later stages, you'll find these proptosis or eye swelling. And majority of our patients, unfortunately, we receive them when they are this advanced, which means somebody missed out on the leukocoria. Somebody missed a squint in a child. If there's anything to take home about childhood screening, it is about squint and leukocorias. They need to be looked at before we reassure parents that they are, it's nothing to be worried about. So when it comes to treatment modalities, we mainly treat our children with chemotherapy, surgery or radiotherapy for our solid tumors. Immunotherapy and targeted therapies are there for just a few cancers, not as easily available. And bone marrow transplants are actually not that common of a treatment. So they are reserved for patients that do not do well. That is for hematological malignancies that don't do well with initial chemotherapy. They do not go into remission. But majority of our leukemias can actually be treated with chemotherapy alone. The most important thing is to detect early and get them treatment early. So part of treatment is supportive care, and there's a host of supportive care treatments that we do give to children. And this supportive care is actually as important as the main treatment that we give, because without proper supportive care, then we are not able to cure them of their cancer. If we do not have a way of doing good infection prevention and treating infections early, giving symptomatic management for their nausea and vomiting and pain relief, treating our oncological emergencies, we will not be able to take care of the patients well. But today I want to highlight this particular supportive care. It's use of blood products. When it comes to MTRH, there are two departments that really ask for a lot of blood. That is the newborn unit and pediatric oncology. The newborn unit asks for a lot of blood, but very tiny aliquots. Pediatric oncology patients require a lot of blood, and we lose a lot of patients simply because we did not have blood for them, blood and blood products. So anyone out there who would want to donate, kindly do so. Encourage people to donate. This actually saves lives. So how is the survival rates? So when you look at the global picture, you see that in North America, you have 10,000 cases with mortality of about 1,000 of that. If you look at Asia, 128,000, mortality 46. In the African continent, you'll find 36,000 and a very high mortality rate of 21,000. So what does that mean? There is quite a large inequality in terms of treatment for childhood cancer, whereby in high-income countries, 80% of children who are brought for treatment will survive their cancer. But in low-middle-income countries, only 20% of them survive their cancer. And WHO has brought up an initiative of childhood cancer to actually address this inequality. The way we can address the inequality is to detect pediatric oncology cancers early. If you detect them early, they're going to be treated early enough, they have better chances of cure. So the reasons for the poor childhood cancer survival rates are the most addressable of them is usually lack of awareness and information on childhood cancers. That is both for parents, for the communities, but also for healthcare workers. We have a lot of education going out there about breast cancer, about cervical cancer, and children sometimes get left behind, but we need to advocate for them because they cannot advocate for themselves. If you have, say, a prominent person with cancer, they are able to garner support and move and better the treatment for that particular cancer. We are the advocates for childhood cancer, each and every one of us. So kindly be more aware of childhood cancer and also teach others to be more aware of childhood cancers. Other things that can hinder survival is usually the delayed diagnosis or wrong diagnosis, the lack of access to quality, cost-effective medicines and treatments, lack of access to trained healthcare providers, and abandonment of treatment. So looking again at our statistics, if you compare the data we have from 2006, 2007, and compare it to 2010 and 2016, you will see that one, the event-free survival at that time between 2006 and 2009 is around 19%. If you look at abandonment, it's a whopping 54%. It means that of all the children that actually got to their treatment centers, 54% abandoned treatment before it was completed. And this is quite a sad tale because the minute a child does not complete their treatment, you actually increase their chances of death due to their cancer. The mortality due to the illness was 22%, with progressive and relapse disease being 4%. And crossing over into 2010, 2016, you find one, the numbers that are actually brought to the treatment centers have doubled. But there are few things that were done between 2006 and 2010 that actually helped improve outcomes. One of them being improving diagnostic capabilities, some modification in the treatment, given availability of radiotherapy, surgical services, but more than that is the supportive care from the community. So you have support for payment of NHIF, having transport kitties, having a patient navigator, and getting better accommodation near the facility, of having options for parents to bring in their children early. And what that has done is to improve event-free survival, 32%, which is about double, and reduce the abandonment by half, that is 28%. This is still quite a high abandonment rate, which needs to be improved upon. But just a few things in pediatric oncology, in the care that we provide, can actually improve survival. And this WHO target of 60% is quite easy to achieve if we all come together and help in achieving that goal. The mortality due to illness actually just remains quite the same, 22 versus 23%. It's this group that needs to move their event-free survival. So, as I said, childhood early warning signs are quite non-specific. So what are we looking for? If a child has pallor, bruising, bleeding from anywhere, or recurrent bleeding and bone pains, these are patients who could be having a leukemia and needs to be investigated for that. If you have a child with lumps, swelling, especially painless, without fever, or even with fever, then this is a patient that needs to be investigated further. Children with unexplained weight loss, fever, persistent cough or shortness of breath, and night sweats. This is a huge percentage of patients that are usually treated for TB, but in actual fact, they might be having something else. One of them being the lymphomas. So eye changes, white pupil, new onset squint, visual loss, bruising, or swelling of the eye. In that case, think highly of retinoblastoma and ask the patient to, or refer the patient early. Abdominal swelling from organ swellings such as Wilms tumor, swellings from rhabdomyosarcoma, germ cell tumors. If you find a mass in the abdomen, suspect cancer and investigate for it. Headaches, as I've said, usually persistent or severe, sudden onset, maybe vomiting, especially in the early morning. This is a child that you should highly suspect to be having a brain tumor and investigate. If they don't have it, well and good, but do not dismiss this. Limb and bone pains, swelling without trauma or any signs of infection. These are children who could be having osteogenic sarcoma. These are sarcomas of bone, if not on the bone and it's on the muscle, could be a rhabdomyosarcoma. Again, make sure that they do get investigated further. So these are some of the patients that we do see, and I'm sure that you've seen quite commonly. This is a patient that you would think is what a classical presentation of childhood cancer, but I assure you it is not. It is a child who is otherwise healthy and has lumps. If they've been having their swellings for quite a while, they might be hectic, but that is a process that has taken quite a long time. This child has been without treatment for quite a while. So this is just another early warning signs poster that you may have seen in your facilities. Please pay attention to these ones and teach others to pay attention to them. What do you do when you have a child with cancer or a child that you suspect to have cancer? So normally in your protocols, you have the referral system that tells you that you have to take a child from the level 1 to the level 2 to the county referral hospital before they get to KNH, MTRH, or KUTRH. When it comes to childhood cancer, I want you to take this quite seriously and focus on this. You do not need to follow the normal referral pathway. We have a special referral pathway for childhood cancer, and it means that you can directly refer patients with suspected cancer to the level 6 hospitals, to the treatment facilities. We have KNH, MTRH, and KUTRH as the public facilities that are currently taking care of cancer patients. Private facilities, we have Gertrude's, Kijabe, Nairobi, and Aga Khan, with just to mention. And part of this direct referral pathway, the ones that have been identified are hospitals with a pediatric oncologist who is able to handle these children. So if you refer a patient to a pediatrician in Baringo County Referral Hospital, they will need to refer that patient to MTRH. And that actually increases the time that they spend without treatment. It delays treatment for them. So kindly, if you see a patient with suspected cancer, direct refer to treatment facilities, whether or not they have a definitive diagnosis. So the take-home messages for today: 1, childhood cancers, the signs and symptoms are very non-specific. We really need to have a high index of suspicion for them. And prompt referral is usually key in getting them cured. We want to improve our survival rates, and the best way to do that is to have awareness of the early warning signs and promptly refer for treatment. So, as I mentioned, the WHO Global Initiative for Childhood Cancer, the goal of which is to reduce, to improve survival to up to at least 60% globally, and especially targeting the low and low middle income countries. So WHO chose 6 common childhood cancers that have a high cure rate and proven therapies. These cancers usually represent about 50 to 60% of all cancers in children. And this is acute lymphoblastic leukemia, Burkitt's lymphoma, Hodgkin's lymphoma, retinoblastoma, Wilms tumor, and low-grade gliomas. So where can you find more information about childhood cancers? There is an online platform. There is an app called M-Saratani, where you can learn about childhood cancer. It has quite a few models, 12 chapters to be exact, and it targets medical officers, clinical officers, nurses, and pharmacists, and it is actually CPD accredited. So you can get your entire CPD points for the year from this platform. Of course, you need to add a few more, but it's a good place to start. There is also the web-based MOH Virtual Academy, where you can have, you can take part in these courses. And after you finish the courses, there is a certificate, and don't forget your CPD points. So for the International Childhood Cancer Day 2023, our theme remains better survival through their hands, and their hands, we mean the children's hands, and early detection saves lives. You're taking part in early detection, taking part in spreading awareness, taking part in getting care for these patients will save their lives. So this is a picture from today, which is our celebrations of the International Childhood Cancer Day at Moi Teaching and Referral Hospital. The celebrations are ongoing in other facilities as well, including KNH. Let's join hands together to
Hello, Dr. Gishemi. Thank you for that overview on childhood cancers. Probably I would like to also emphasize on the need for early detection, which actually leads to high survival rates, especially for our children. And also thank you for taking time, especially for taking us through detection of early warning signs for children, and also the need for prompt referral of these children. So for the attendees, kindly keep your questions in the chat box. I think after the next presentation is when we will delve into them and probably tackle any pending questions that might be there. I'd like to introduce our next speaker for the day. That is Dr. Esther Mwinga. She's a coordinator for pain and relief and palliative care, currently with the Kenya Hospices and Palliative Care Association, KEPCA. Daktari, karibu.
Thank you very much, Dr. Orangi, and thank you, Alice, for the overview of childhood cancers. So I'll move to the aspect of palliative care for these children and their families. So children living with cancers, what can we do? So by way of introduction, we need to understand what palliative care means, what it refers to. And when we are talking about palliative care for children, we look at their care of their body, mind, and spirit, and then of course support to the family. And we look at what this entails when we are talking about children's palliative care. It's important to remember that it should begin from the time of diagnosis and continues whether the child is receiving a treatment directed at cure or not. But remember, Dr. Alice has reminded us that for childhood cancers, most of them are actually curable if detected early. So in terms of our goals of palliative care, of course, it's given as they're seeing the oncologist or the specialist. We are looking at improving the quality of life of this child. We are looking at comfort and dignity in death. We are looking at supporting the family during the child's illness and also in bereavement. And for childhood cancer, there's a lot of benefits when you include peer support. So look at how to bring caregivers together, bring the children together so that they share experiences and they also support each other through this journey. Remember, when you get a diagnosis of cancer, it's a life-changing, life-threatening situation. So a lot goes on and there's a lot of need to support these patients and families holistically. So when we are talking about when you're talking about who requires palliative care, you look at the different conditions that would benefit. And today's International Childhood Cancer Day is focusing on cancer. So this one falls in bullet 1, where we're talking of conditions where curative treatments can fail. So there are many options or many examples that you can give, but cancer is one of them. There could be conditions where death is inevitable, but after years. So things like sickle cell, cystic fibrosis, they would also benefit from palliative care. Progressive conditions like the nervous system disorders, and then irreversible but non-progressive diseases. Things like AIDS, remember they're getting ARVs, but then they also have irreversible condition that's affecting the way they live and how they their immunity is. So there are many other conditions that could benefit from it, from palliative care. So even when we are taking care of children with other diagnoses, not just cancer, remember that they can also benefit from palliative care services. A reminder, when we are taking care of children, there are differences with how we take care of adults. And for children, we would not refer to them as mini adults because they see and feel the world in a different way, and their development really affects how they perceive their illness or their condition that they are in. So because of this development and the environmental factors, how they react to care and treatment and this journey of oncology really differs. So for them, a serious illness is really not normal. If you're looking at the differences between taking care of an adult and taking care of this child who has a diagnosis of cancer, then decisions for these young children are usually made by caregivers as opposed to the children, especially if you're looking at those below the age of 18, which is where for us in Kenya, that's when you're able to make decisions on your own. But then in the wards, different wards, some may not admit children less than 12 years, others less than 14. So medical decisions would typically be made by a guardian. And then for children, we need to remember that play therapy is part of this care. And then what we offer to them will be tailored to the child. So we talk about individualized treatment plans for these children. So you cannot say a 4-year-old being taken care of at Ekaret would have the same care plan as a 4-year-old being taken care of at Kisii. You need to assess and see what works best for them. The World Health Organization emphasizes on the need of including play within their daily life. So even as you're taking them through therapy, you're taking them through the oncology treatments that have been highlighted in the session before, play has to be included because it helps them cope better with the illness, and that's the language they actually understand. So some of the needs these children would have if they have a diagnosis of cancer, and this is where palliative care teams come in, would need to assess and manage their quality of life based on the symptoms that they're exhibiting. So because their development, their verbal status would really affect how they cope with this, a comprehensive assessment is important. And here you need a team to help you do an appropriate assessment and care for them. Issues with communication with the child, with the guardians, and then the aspect of breaking bad news. How do you tell them, Mama XYZ, your child now has diagnosis ABC, and this is the journey we are going to be working with you. Another aspect that children would need the support of the palliative care team is the psychosocial assessment and management. You're looking at their social needs, their psychological needs, financial. There was a mention of abandonment of care, and I know that is determined by very many factors, one of them being financial, but then the other thing is how do these patients and families cope with this difficult diagnosis. So you have to do a good psychosocial diagnosis and give them an appropriate management plan. So the psychologists do come in, the counselors or whoever else is well trained in this area. They have also spiritual needs that need to be addressed. So your spiritual caregivers are an important part of your multidisciplinary team. The aspect of play that has been emphasized by the World Health Organization. Do we have play areas that are suitable for our children as they're receiving oncology services? I know KNH, MTRH have really put resources towards this because it really motivates the children and makes them forget about the illness at that time. End of life care, how do you work with this child who has gone through treatment? Maybe it has not been, cure has not been possible. They are at end of life. How do you communicate with the child and the family? And how do you talk also to the siblings? Management of ethical dilemmas. There are issues about don't transfuse blood. The child needs transfusion, but the religious beliefs that are making this a hindrance. How do you navigate that so that it is also culturally appropriate for this family you're dealing with? And then if the child dies, how do you help them cope with grief and bereavement? Because this is an important part of care. Even if the child is not there, the family who's left behind will be mourning and they need your support as a palliative care practitioner. Physical needs are usually the greatest for these children. And remember, for the physical symptoms, some are because of the illness itself. So before diagnosis, they have symptoms. When they have the diagnosis done, probably the disease is progressing. There'll be different symptoms. And then the medication they're using might also give them other unwarranted side effects. For example, chemotherapy causing nausea and vomiting. So how do you handle that? So sometimes taking care of children's symptoms is hampered by the lack of the ability to self-report if the child is young or if the child is not able to talk because of developmental challenges, unavailability of proper assessment tools. So in your facility, do you have proper assessment tools that are targeted for children? Remember, we said they're not small adults, they're just children. An awareness or reluctance of the healthcare professionals to actively seek symptoms. So do we ask when the child comes for their chemotherapy treatment on Monday, are we keen to ask if they've had any symptoms over the weekend at that time? Have they had adverse side effects that maybe might not come out if you don't ask? So reluctance on our part as health professionals, and then problems with using certain medications, especially I know we have a lot of healthcare professionals who are against use of opioids if you're taking care of severe pain in these children. How are we comfortable with that? Are we comfortable in assessing and giving the right pain medication using the two-step ladder for children by WHO? Then availability and proper dosing of medication, and that also affects, I know a lot of the preparations that we have would see pharmacists making the formulations suitable for the children based on the age. So is there a way of making sure that for all the medications we are able to prescribe based on our guidelines, we have formulations that are appropriate for children without having the teams in the facilities to make adjustments, which might lead to errors of dosing and other effects. So when you're talking about pain, that is one of the physical symptoms. We have to remember it's not just physical. We have what we call total pain. So there could be psychological influences or psychological issues. There could be cultural ones, spiritual and social. So even as we are assessing or as we're taking care of this child, just about looking at the tumor cell count, looking at the white blood cell count. We also have to look at, for example, social issues. We've had issues about stigma. Is the community supportive of this family, supportive of this child? Are they facing abandonment by their family, abandonment by their caregivers? We've had issues of children brought to KNH. They have a diagnosis of cancer. It needs a prolonged therapy, and then the parents leave them alone. So is this child able to go through treatment successfully? Those are the things we also have to consider. So in terms of communication, remember I talked about the developmental level really affects how they communicate, but there are three main languages that we can also read or hear from them. Number one being body language. So you can see how the child is behaving and know they might be going through something. Are they happy? Are they sad? Play, how they interact with other children, and sometimes how they write or what they draw can give you an idea of what they are going through. And I know a place like MTRH with the child life specialists, they've really incorporated play therapy and holistic child care, even as they go through treatment and therapies by the specialists. So play language and then finally spoken language, what they're able to verbalize. So there are things that might influence how we communicate with them, and some barriers that come from ourselves, from the society, cultural barriers, language, patient factors, ourselves as health professionals and making assumptions. And then I've heard of this other fear of we are fearful of taking care of children because they're young. Maybe you feel for them because they're children, really. So there's something about the emotional aspect that might affect how you actually connect with this child and the family. And then finally, lack of skills. And that's why we keep having this conversation so that you also build your confidence, build your skills and your knowledge in terms of care of these children and their families. So overcoming these barriers has a number of ways we could engage in. One is learning and getting to know something new you can do, or knowing where to refer this child if you're not able to take care of them. Taking time off so that you allocate them enough your attention, and you're able to get their nonverbal and verbal communication feedback from the child and from the family. Respecting their space, making the environment child-friendly, offering regular support and praise. This is a language children really enjoy. And they know even when you talk about putting a Branula on their hand, there are many things you could engage in so that they get, you get the buy-in from them and they agree for you to do a certain procedure on them. Explaining what you're doing depending on the child's developmental level, if they're able to understand, and then avoiding assumptions. So always ask and hear from the patient and the caregiver. And I know a lot of times it will be, you have a 9-year-old, they've come to the clinic, but you're talking to the caregiver and not to the child. So the child is just seated somewhere and you're discussing with the patient. And in this situation, your patient is able to give you information that would be useful to you. So in terms of progress in children's palliative care in Kenya, we have achieved a lot of milestones. And I'll just focus on the few recent ones that are relevant to us. We have a national palliative care policy, 2021-2030, that is also on the Ministry of Health website, that would guide you even as you implement palliative care services and palliative care services for children. Palliative care is also highlighted in the National Cancer Control Strategy, which is under the Ministry of Health, led by the National Cancer Control Program. There are different TWGs, technical working groups, that focus on advancing palliative care services. And then if you're setting up a cancer center, the National Cancer Center Establishment Guidelines also give you direction on what to include or what to focus on when you are having the palliative care center within your oncology facility. There are also training opportunities, certificate and postgraduate training programs that include children's palliative care. The M-Saratani platform, which is an MOH platform, also has palliative care embedded in that. So take time and also just get to learn by doing some of these free courses, because you're not going to be paying for it, but you're actually benefiting from the knowledge you gain. There are also online children's palliative care courses. There are a few organizations that are offering this, and you can also sign up and have your knowledge improved on this, including the International Child Cancer Network, ICPCN, and many other platforms that you can look up. The recent palliative care conference that was in November 2023 had major tracks on childhood palliative care. So this is also a forum for us to interact as professionals across the country or across the world, and learning from each other on palliative care. As Kenya Hospitals and Palliative Care Association, which is the umbrella body for palliative care services in Kenya, we have a project called My Child Matters, which is really aiming at scaling up palliative care services for children, because we have the services available for adults. We have palliative care providers who've gone to school, but now we need to build up this for children so that even as they're going through the different therapies, they're also receiving palliative care services. So calling upon all of us as champions of palliative care, we hope to have more champions in the counties, so that the person at level 2 facility, the person at a level 3 facility is able to get some form of palliative care service as appropriate to them. And referrals are also in good time so that we improve the survival rates of these children. When we talk about a good environment, this is just food for thought. If we had awards as picture A or picture B, if you are the child, you also have to put yourself in the shoes. Where would you rather be admitted? So this is just going back to the point that the environment where the child is being taken care of really has a big bearing on how the childhood outcomes actually are. And that's why a lot of facilities and institutions are putting resources to make sure we have play therapists, we have reading, we have education, and we have just time for them to be children. Remember, they're still children and they're growing up. So this is a question for all of us. Children living with cancer need to be involved in their care and decision making. So in your opinion, do you think they should be involved or shouldn't they be involved? So it's a true or false answer. I don't know what your thought is, but if the chat is open, that can be put in. But the question for us to consider, children living with cancer need to be involved in their care and decision making. Is that true or is it false? So in conclusion, what we are saying is that palliative care for children is the active total care of their body, mind, and spirit. and involves taking care of their family. And this begins from the time of diagnosis. So whether they're at a good place in terms of the diagnosis, it's early, or is it there at the end of life, they would still benefit from a form of palliative care. And the siblings also have to be remembered, because most times the parents will focus on the child, focus on taking the child for clinics, and forget the other siblings who need support with their homework. They need support with the extracurricular activities. So sometimes the siblings feel left out. So as we're taking care of that, we need to remember the family, the child, and the siblings, and then of course the community. Thank you for the responses. True. Yeah, so depending on the child's developmental level, I'm sure there's a way you can always communicate with the child, even as you talk to the caregiver. So as we are looking at our goal of better survival through our hands. So think of, what are you able to do to improve the child's survival? What can't you do? What are you able to refer? And how else can you keep improving your knowledge and your skills so that you become a better health professionals taking care of these children? Thank you very much for your attention and your active participation. I'll stop there. Thank you.
Thank you very much, Daktari. In regards to that presentation, as probably you can see, the level of, I think, the heart emojis and the congratulations that are streaming in, I think it was very insightful, and a lot of people, I would say, paid attention in regards to the same, that is palliative care and survivorship needs for children with cancer. Probably main thing to note is children with cancer are not only treated, or probably is a major concern in the tertiary level facilities, but this is something that transcends from tertiary, from down in the moving up to the primary care, secondary care, and up to the tertiary care for that child. Thank you very much in regards to that. We had a poll. I think the KNH team probably can put that up before we go to our next presenter, at least so that people can be reinvigorated and we see if knowledge has taken place in that regards. Okay, so while we wait for the poll, so part of what is happening today, because we are actually celebrating the childhood cancers. There we are. Very good. So I would probably request our attendees to take a few minutes to kindly go through this and answer the questions. They are very simple. Most of this has been presented. We'll give each question, I think, 1 minute. Thank you. Okay, next question. Next question, please. Next question. And the final question, please. Next question. So, so the question reads: the global initiative for childhood cancers aims to reduce the survival gap by 2030 by making sure that at least 60% of children, so it's children, not children, with cancer will survive their diagnosis. True or false? Okay. I think that's enough time. So we will move on to our final speaker for the day. So one of the things about children is we have the involvement of their parents or probably their treatment supporters in regards to the same. And for this session, I'd like to invite Julian Maina. She's on the call. You can unmute and probably give us a small description and also probably the journey on taking care and probably also living with a child who has cancer. Karibu. Welcome.
Hi.
Hello. You can move somewhere.
Hello. 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 I'm not Julian. I'm Mama Abi.
Yes, Mama Abby.
And Abi was diagnosed with nasopharyngeal carcinoma for the last 1 year. It has been a hard journey to take care of the patient, to work up the finances. Sometimes we get the the cards are not working and child cards. We find sometimes there is limitation. So at some point you are stuck, you don't know what to do next. At times you are given clinics, and these clinics are expensive as a parent. So if you don't have any support from the family, from the friends, sometimes you fix to come for the clinics, which is very dangerous for our kids. So for us parents, we just ask whether it is possible for the organizations, some organizations of well-wishers who are willing to help the parents to these kids, they can just offer support through financials. They can also, the government can help in dealing with these children with cancer, that their cards can, there is no limitation for the card. So the baby can go through the treatment without no limitations until the child is stable. Other problems that you find is sometimes you find people neglect you from your family, your spouse might neglect you, parents might neglect you, and sometimes we as parents, we have hard time. Psychologically, we are traumatized. We don't know the journey, how are we walking with this journey, hatujui itachukua muda gani. So we need moral support, financial support, social support. We have much to do. Yeah.
So,
Hello.
apologies, I think there's a background noise,
Yeah.
but I hope you can hear me.
Hello.
We can. So, one more final question.
Yeah.
So, probably, what are the challenges you face, you as a caregiver?
Me as a caregiver,
Yes.
finances, just finances. Finances is more dangerous because me as a parent now, I expect to see my child doing good. Yeah, I would like to see my girl stable. Sometimes you find I have no cash to take her to the clinic. So finances, I think, is the most. I
Is
think
it,
that's the traumatizing part of the treatment.
so,
Yeah.
two more queries. First of all,
Yeah.
what are the main
Okay.
signs and symptoms that you saw in Abby that made you suspect that there was probably not normal or something wrong in the probably you suspect Abby well?
Habib was training weight every day. And at first, before the diagnosis of the nasopharyngeal carcinoma, we were diagnosed with extrapulmonary TB. And this treatment was to take her whole here. Then suddenly, after 2 months, we had to do another biopsy, which turned to cancer.
So
Yeah.
how did the doctors give you once you got the diagnosis? Were they receptive? How did they explain to you her condition?
It was, I think for me it was easy because now I've been walking in and out of hospital, and now it reached a point that I wanted to know where my kid is suffering from. So for me it was easy. I didn't take, at first sikuchukua kama ni kitu kubwa, but with the time nilipata with a lot of support from the doctors kunieleza what is this, but at first sikupata hiyo kitu kwa uzito. It hit me after a short time, but mentally I was supported very well.
So right now we are in a better position.
Yeah.
You can hear me?
Excuse me. Yeah.
We are you, do you feel like you're in a better position in understanding Abby's condition right now? Are you in a better position to understand what she's going through? And also to allude to what previous presenter Dr. mentioned,
Yeah.
he has, I'm asking,
Yeah.
you can hear me?
Yes.
So are you in a better position to understand Abby's condition right now?
Yeah. Yeah.
Okay, and does Abby have an idea about what is going on?
Yeah. At first, I did not tell her,
Uh-huh.
but through the treatment and the doctors, and sometimes Abby is a 10-year girl, so they share with the other kids, they meet with them. At first mimi sikumwambia, but alipata kupata watoto wengine wanasema, me you know I'm suffering from this, me you know I'm suffering from this, na mpaka akakuja akaniuliza, mama, kwani mimi shida yangu ni gani? You know, I kept on hiding because he used to ask me, mom, I see this is a cancer ward, and tumesoma shule at there are curable diseases and uncurable, and I know cancer is one of the diseases that are not curable. Now, I had time to explain, but he later told me, I know my diagnosis and I'm okay. I know I will not die. Mama will survive. She's a positive girl and she has really improved.
Wow,
Yeah.
very courageous.
Very courageous.
Nice. That's excellent. So probably as a parting shot, what would you probably say in regards to the healthcare workers or fellow parents or children who are actually going through the same issue, that is a child with cancer? Bearing in mind this year's theme actually put it on the chart, the better survival through our hands. So our hands will be you, me, and all of us. What probably would be your parting shot or your last question?
I don't get you clearly.
I'm asking, what is your advice? Probably to those who are maybe going through the same ordeal.
My advice is cancer is not a killer disease. You take it positive, you support your kids, mahali unaweza, do it perfectly. With the doctors, they are doing their best. And I want to thank them, especially the KNH oncology system. Wanasaidia sana watoto wetu, they are stable, they ensure that everything they need is there. So to the parents, I tell them cancer is not death sentence. And the one who heals is God. So we give our children to the doctors, they treat, and we pray God for the healing of our kids. That's the only thing I would tell them.
Thank you very much for that. You have literally summarized what Dr. Esther Mwinga presented in regards to education and also the support that's supposed to be given to the healthcare givers, the children, their parents who are out there. We will also continue to strengthen, hopefully through this forum, the health system. I know there are people who can make decisions who are on the and probably they have had your sentiment. I'll leave it at that, and then because of time, will allow me, we'll move to the Q&A section for the day.
Thank
so
you
we
for
have
the engagement.
Karibu sana. We really appreciate your audience also.
Thank you so much.
So to our two panelists of the day. We have several questions. I would kind request to those, thank you for muting the background news. So we have several questions. I'll quickly go through them. Probably for our panelists, you can note them down, and then we can answer them wholesome from the chat box that is there. There is an anonymous attendee who is asking, is there a study on the quality of life on patients presenting with aggressive maxillofacial cancers, especially those who undergo maxillectomy, considering the defect left post-surgery? The second question, I think this one is directed towards Dr. Alice. We had a child that presented with severe malnutrition recently. At what time do we consider screening this child? The case was screened late and ended up being gastric late. Then we consider screening children as early as the second visit. We need to mute somebody. There's some background noise. Well, thank you for that. Then the second part is, do we have a protocol for childhood cancers that can be shared? That is coming from Eddie Omuture. The next question is arbitrary, but can be answered. What's the role of nuclear pharmacists, and do they impact the treatment process from the initial stage? That is from Evans Keegan. The next question again is for Dr. Alice. Why is such a high rate of treatment abandonment, and what are the side effects? The assumption is the side effects of treatment abandonment. I think part of that was answered in the presentation, but again, if you can elaborate, will be good. And then the second part of that question is, there most recent data on the treatment outcome for childhood cancers? There's a question from Fauzat Hamid. I hope I'm pronouncing it well. How do you go breaking the news to a family of a child with cancer? I believe this is where we have failed. Most of the patients are not being well prepared. That's the quality of life for the patient, and the whole family goes down. So basically the question is, how do we break the news to the family of the child with cancer? Geoffrey Tomani is asking, when do we suspect squint as a sign of cancer? Is it at birth or any age during childhood? For second part is for leukocoria, how is it differentiated from cataract? And is there additional feature to support leukocoria as suspicion to cancer? I think that one will be directed to Dr. Alice. Probably we can delve into those, and then we look at any other that might be out there. Thank you. So the floor is open. Probably we'll start with Dr. Alice, if it's okay. Thank you.
Okay. Thank you very much for those questions. I'll start with the question on malnutrition. A child who presented with malnutrition initially and was found to have cancer. I think, as we said throughout the presentation, having a high index of suspicion for cancer is important for healthcare workers. So when you have a child with severe malnutrition, it's not enough just to treat the malnutrition. You have to look at why they have malnutrition. Is it a nutrition issue? Is it infections? Is it cancer? So where we fail is to treat symptoms when children present, rather than looking or delving into why they are the way they are. So a child could be having malnutrition because they do not have the right foods at home, or whether in amount or types. They could have malnutrition because they have TB. They could have malnutrition because they have cancer. Again, how we handle patients when they present is actually quite important for us to be able to delve into the why of why they have that malnutrition. The second part asked about whether we have protocols for childhood cancer. Yes, there have been protocols that have been done in MTRH, and these same protocols are used in KNH. We do, as part of pediatric oncology, we want to have a comprehensive way of dealing with childhood cancers, and we try as much as possible to develop protocols on what is the best treatment modalities for our children here in Kenya. So the protocols exist, they are available. The one thing I'd want to emphasize about it is that kindly do not attempt to treat childhood cancer without a pediatric oncologist or the guidance of a pediatric oncologist. We do have other oncologists in various facilities, but they do also require to have MDTs with pediatric oncologists. So these protocols can be used in such cases. The next question was on, just a minute, where is there a high rate of treatment abandonment? Is it because of side effects? And the simple answer to that one is actually no, it's not about the side effects. There is actually a study that was done on the reasons for abandonment, and among those children, among those parents who had abandoned treatment, the most common reason that was given was actually financial difficulties. That was at 46%, followed by inadequate access to NHIF. So these reasons have since improved due to better coverage of NHIF, having poor support from the community, and sometimes it's just seeking alternative medicines. And some of the patients that had abandoned care felt that their child was well enough. So if a child comes in with a huge mass on the jaw and they're given 2 courses of treatment, this tends to shrink to a point where the parents see that as cure just by looking at it. But that is incorrect. Even when we start treatment, we really do need to emphasize completion of the treatment as per the protocols. Is there more recent data on treatment outcomes? For overall treatment outcomes, we have not yet published any more data, but there are a few publications on ALL and Wilms tumor. I believe there is a publication for Wilms tumor up to 2016, I believe. And that one showed an improvement in survival. Overall survival was at 67%, which is quite good, but still requires improvement. And that study showed that about 70% of patients were presenting with stage 3 and 4, which is something that we really need to tackle. With improvement of radiotherapy, the 2-year event-free survival for those that underwent radiotherapy in addition to chemotherapy and surgery had an event-free survival of 86%. So studies do help us to know exactly where we are and what we need to improve. There is ALL study that looked at data between 2017 and 2020. This one is a manuscript that is awaiting publication that showed an improvement, a significant improvement of 23%. That is from 18 to 40% event-free survival, which makes the overall survival much higher, closer to 50% in those children. Yes, we do need better publications. Unfortunately, it does take quite a bit of resources to do research, and we are hoping with the support of the National Cancer Institute, we'll have better data to base our treatments on. The other question was on squints and leukocoria. Let me just bring it up. So, is there a difference between leukocoria for cataract and leukocoria for retinoblastoma? The simple answer is no. So if you look at causes of leukocoria. We have, you can have congenital cataracts, you can have retinopathy of prematurity, you can get that leukocoria from toxoplasmosis, vitreous hemorrhages. And the important thing about it is that most of these conditions, if not all, are vision threatening. And retinoblastoma is life-threatening. So anytime you have leukocoria, again, this child must be seen by the ophthalmologist, and we should make a point of making referrals to ophthalmologists more frequent, better. Sometimes we do send patients to an eye clinic that does not have an ophthalmologist or even the capabilities of having a good look at the eyes. So we need to be more specific about where we are sending our children when we find that white reflex. About the squint, sometimes if a mother comes to you concerned about a squint, just pay attention, believe them, give them the care that they're asking for. They're asking for, could you look at this? Could you have a look and tell me whether this is normal or not? If you do not have the training for that, again, refer this child to the ophthalmologist, not to the optometrist, not to the optician, to the ophthalmologist. A mother who has seen a squint just once and it disappears will not come to you. This is a patient who has likely have had a persistent squint. A persistent squint in young children is not normal. Have them get looked at. A squint that appears at 3 months of age and above is not normal. Have that child looked at by the ophthalmologist. What we look at as squints that usually come and go and disappear with time are squints that are there before the age of 3 months. And these are squints that you see it, now you see it, now you don't. Now you see it, now you don't. They're not persistent. It's something a mother might catch once and then be very unsure of whether they saw it or not, because it's not persistent. Those usually go away. But if a patient comes asking for help about squints, refer appropriately to the ophthalmologist. The other question, let me just look through it. I don't know if I've answered all the questions.
That covers, I think, most of what I can see from our end. Probably I'll give the floor to Dr. Esther. I think there are some few questions to her end.
Thanks. There was a question about breaking bad news, or basically communication. It would also be good to hear from the oncology teams. How do you usually handle it practically in your facilities? But the recommendation is that the person dealing with the patient, or the primary health professional, if you are the one who started the journey with the patient, remember communication starts from the time of diagnosis. So when you're sending them for investigations, there has to be some messaging done around why are we doing this investigation, what are we looking for, what might we find, so that it becomes easy once the results are out. You're able to say, based on our conversation XYZ, we have your feedback of your CT scan or blood work, and this is what it shows. I know the challenge has been we delegate the issue of breaking bad news to maybe someone who has not been with the patient, or someone who is not ready to start up that conversation, because breaking bad news has never been easy, but it should be done. So the recommendation is that if you are the primary health professional taking care of this patient, it will be your responsibility to make sure that that news is communicated to the patient and the family. So it can be done with you and a team member, maybe during a family meeting. but you have to give them a warning shot. If the news is bad, of course it's bad news. You have to give them a warning shot so that they anticipate that. But I know a number of us have had patients going through treatment and they never know their diagnosis, which really also contributes to abandonment of treatment eventually. There was the question on the e-learning platform. It's MOH Virtual Academy. So if you type that on your browser, you'd be able to see that and enroll for a course of your interest. So there are courses on different cancers on that platform. I don't know if there was another question to me. Over to you, Gavin.
So thank you for that. I can't see any other question that is directed towards you. Probably I'll address somebody had asked in regards to the role of radiopharmaceuticals in pediatric cancers. So yes, they are actually used for pediatric cancers. I am aware that we can use radiopharmaceuticals for indications like neuroblastomas, thyroid cancers, and some bone-related cancers. I think that covers it for today. I would probably like to thank everybody for their attendance for the day, for taking time for this meeting, and then also for helping us. I think we have all been educated in one way or another in regards to childhood cancer, the various forms, and Dr. Alice took us very well through that, and also the challenges that are faced by young children and patients and their families. I think there was Mama Abby who was on the call and also gave us a bit in regards to that. And then also the palliative care for these children and also their caregivers in the same regards. While we go with our theme for the day, I would like to give the last parting shot from the Q&A section. There's somebody who mentioned something in regards to what Mama Abby said, whereby she said that the child said that, "Mom, me, I won't die. I am strong." Those are very strong statements, and I would like to also echo that. And us as healthcare workers who are on the call, and also guardians or whichever sphere that we play in the management of childhood cancers, probably it's something that we also need to take into our heart as we also strive to improve the quality of care that we give to our children, so that we can actually make small strategic investments that can save lives and also improve the overall healthcare system and also the healthcare of the common mwananchi. Thank you. I was your host for the day, or your moderator for the day. I apologize for that. I would hand over to the KNH team, and I think members can leave at their own discretion once that is done. Thank you.
All right, thank you, Gavin and team. It has been an insightful presentation. You are welcome here on again to discuss on childhood cancer. You can see the responses that we've gotten. It has been a good session. And as we're approaching the close of our webinar, kindly remember that for any CPD queries, you are instructed to channel the follow-up through knhcpd@gmail.com. The session has been recorded and will be uploaded to our YouTube and KNH sites. And also, please note that we'll be having a session tomorrow in the evening from 7 to 5:30. That will be a pediatric series, and we'll be looking at renal disease in pediatrics. Thank you once again for joining us. See you again tomorrow.